This session will focus on assessment of the right ventricle. While the left ventricle tends to be the focus of exams, the right heart plays a critical role in cardiac function and requires careful assessment. The structure and anatomy will be compared and contrasted with those of the left ventricle in order to bring a greater understanding. Subsequently, we will discuss techniques for assessing right ventricular function, especially tricuspid annular plane excursion, or TAPSE. We will review echocardiographic views used in the assessment of right heart structures. Finally, we will identify normal and abnormal echocardiographic appearances of right heart structures. The anterior and inferior borders of the heart are formed by the right ventricle. From a surgical perspective, the cardiac chambers in the front of the chest following sternotomy are the right atrium and right ventricle, much like the image in the top right of the slide. Notice that the right ventricle is not a pure bullet shape like the left ventricle, but is more pyramidal and amorphous. It should not co-dominate the apex, but terminate prior. In the short axis, it should appear significantly smaller than the left ventricle and has sometimes been described as a hand, RV, on a basketball, LV. The right ventricle is formed by a free wall comprised as anterior and posterior components and the interventricular septum. The tricuspid valve has 3 papillary muscles and 3 cusps. The 3 cusps are anterior, posterior, and septal. We will discuss identification of these cusps later. It is important to note that the tricuspid valve sits 2 mm more apical than the mitral valve. Some congenital heart defects will result in a more basal position of the tricuspid valve, along with other significant structural anomalies. Despite only having 1/6 of the muscle mass of the left ventricle, the right ventricle generates equal output to the left. Right ventricular shortening occurs in the longitudinal plane. The contraction creates a lower systolic pressure that peaks early. Since blood flows down a pressure gradient, this early systolic peak pressure sets up the gradient for blood flow throughout systole. The pulmonary flow occurs because of the inertia created with it. Right ventricular function can be assessed by measuring fractional area of change. FAC for the right ventricle is calculated in the same way as that of the left ventricle. You can see the left ventricle systolic function module for details. First, you subtract RV end systolic area from RV end diastolic area, then divide that number by RV end diastolic area and multiply the result by 100. Tricuspid annulus plane systolic excursion, or TAPSE, is measured by placing an M-mode cursor through the lateral tricuspid annulus. Less than 1.6 centimeters of excursion toward the apex in systole is abnormal and suggests impaired right ventricular function. Tissue Doppler imaging of the tricuspid annulus and right ventricular free wall is another modality which can be helpful in assessing RV function. Finally, myocardial performance index can also be applied to the right ventricle. We will deal with this measurement more in the context of left ventricular function, but want you to be aware that it takes into account both systolic and diastolic function. An MPI greater than 0.55 is abnormal and suggests impaired RV function. This slide shows a variety of views useful in assessment of the right heart. The most useful views are the mid-esophageal 4-chamber view, the mid-esophageal RV inflow-outflow view, and the transgastric views. The 4-chamber view shows most right heart structures of interest. It allows the viewer to see the RV lateral wall, sometimes referred to as the free wall, the interventricular septum, the right atrium, and the tricuspid valve, and is thus a useful starting point for evaluation. The RV inflow-outflow view allows visualization of the tricuspid and pulmonic valves, as well as the RV lateral, all quite clearly. The basal and mid-transgastric short-axis views can show RV wall function and leaflets of the tricuspid valve. The transgastric RV inflow view can be useful to see the subvalvular apparatus of the tricuspid valve and further identify leaflets. The next several slides will discuss each view in detail. The four-chamber view of the right ventricle allows the viewer to see the right atrium, right ventricle, and tricuspid valve. The tricuspid leaflets seen are the anterior and septal leaflets. Color flow Doppler can help assess for tricuspid regurgitation. The RV can be assessed for size and thickness as well as motion, which we will discuss next. RV functional assessment is largely qualitative, based on observations of wall thickening and motion. In systole, the RV moves towards the apex. Tricuspid annular motion can be assessed both visually and with M-mode echocardiography to look for TAPSE. Recall that the tricuspid valve should move at least 1.6 centimeters toward the apex in systole for function to be considered normal. Observe the right ventricular function, motion, and size of the right atrium and ventricle in this slide. Also note the even plane of coaptation of the right ventricle. This represents normal right ventricular structure and function. The RV inflow-outflow view is shown in schematic at the left of the screen. It is so called because you can identify the path of blood flow from the right atrium through the right ventricle and into the right ventricular outflow tract in the same view. It is particularly useful for watching the placement of a pulmonary artery catheter. The anterior and septal leaflets are again seen in the RV inflow-outflow view. Note again the dynamic nature of the RV lateral wall and the excursion of the tricuspid valve in systole. This slide presents a normal right heart seen in the RV inflow-outflow view. Later, you will observe some abnormal hearts with which to compare this normal view. Note the probe position between 40 and 60 degrees. The aortic valve is also clearly seen in short axis in this view, while the tricuspid and pulmonic valves are seen in long axes. In the transgastric basal view, you can see all three of the tricuspid valve leaflets. Moving clockwise from the top, you see the posterior leaflet in the 12 o'clock position, the septal leaflet at 3 o'clock, and the anterior leaflet at 9 o'clock. This is the only view where all three tricuspid leaflets are visible, and it is often difficult to see all, even in this view. In the transgastric RV inflow view, the posterior and anterior leaflets of the tricuspid valve are visible, along with the subvalvular apparatus, the right atrium, and the right ventricle. CVP can be estimated by evaluating collapse of the right inferior vena cava in spontaneously breathing patients. Full collapse of the IVC suggests 5 millimeters of mercury of pressure in the right atrium. Greater than 50% of initial diameter of the IVC suggests 10 millimeters of mercury of pressure in the right atrium. Less than 50% of initial diameter of the IVC suggests 15 millimeters of mercury of pressure in the right atrium. No collapse of the IVC suggests 20 millimeters of mercury of pressure in the right atrium. In the upper esophageal aortic valve short axis view, the pulmonary artery can be seen adjacent to the short axis of the aorta. Flow in the pulmonary artery at this point is parallel to the Doppler beam, making it a useful view to trace a velocity time integral through the pulmonary artery. This can be coupled with a calculation of the cross-sectional area of the pulmonary artery to result in a right heart-based cardiac output calculation. The bicaval view is seen by positioning the probe over the right heart and rotating to 90 to 120 degrees. One use for this view is to look at the superior and inferior vena cava to conduct assessment of volume status. These assessments are most accurate in spontaneously breathing patients. For the vena cava, a diameter of 2.1 centimeters or less and collapse of greater than 50% suggests a CVP between 0 and 5 millimeters of mercury. A diameter of over 2.1 centimeters and collapse of less than 50% suggests an elevated CVP of 10 to 20 millimeters of mercury. If the SVC diameter and collapse pattern don't fit either of these categories, the CVP is often 5 to 10 millimeters of mercury. This slide represents a modification of the bicaval view where the probe was advanced in an effort to follow the IVC into the liver. In this image, we see a large dilated IVC surrounded by liver parenchyma. Given that the IVC measures greater than 2.1 centimeters, the CVP is likely elevated to between 10 to 20 millimeters of mercury. Another application of the bicaval view is to use it to focus on the tricuspid valve, which usually appears around 8 o'clock on the screen. In this view, the Doppler beam can be aligned easily through the valve. Color flow assessment can also be completed in this view. A continuous wave Doppler of the tricuspid valve can show the TR jet. Using simplifications of the Bernoulli equation, 4 times the peak velocity squared represents the pressure gradient between the RA and RV in systole. Adding this to the CVP would therefore give the peak RV systolic pressure. Since the pulmonic valve is open in systole, the pressure between the RV and PA are equal, so this also represents the peak PA systolic pressure. The RV inflow-outflow view can also be used to the same result in calculating PA peak systolic pressures. On the right of this slide, we see an example of a continuous wave Doppler through the tricuspid valve, which has a velocity of 2.3 centimeters per second. 4 times this velocity squared, therefore, yields a peak gradient of 21 millimeters of mercury. If the CVP is known, it can be added to this to give the peak PA systolic pressure. In this 4-chamber view, we see the interventricular septum being pushed into the left ventricle in systole. This suggests that the pressure in the right ventricle is higher than that in the left. The same can be said of the interatrial septum, which is also bowed to the left atrium, suggesting high right atrial pressures. RV wall thickness is measured in diastole. A measurement of over 5 millimeters of mercury suggests hypertrophy, consistent with chronic pressure overload. Examine the size and movement of the right ventricle in the images on this slide. Note the dilation and poor lateral wall motion in each. The image on the right shows a classic bowed or D-shaped septum, suggesting pressure overload. In this slide, the RV is moderately hypokinetic, with the apex more affected than the base. Note the tricuspid annulus still moves toward the base, though not normally. The mid and apical portions of the RV lateral wall become progressively less contractile. It is important to think about the 3 main causes of RV failure: tamponade, PE, and RV failure from infarction. Each has a characteristic set of findings, which we will review in the next portion of this session. Cardiac tamponade manifests as a pericardial effusion coupled with chamber collapse during the period of lowest chamber pressure. Thus, the RV may show diastolic collapses and the LA systolic collapse as evidence of tamponade. On the left, we see a transgastric view of the left and right ventricles with large pericardial effusion behind the heart. Notice the collapse of the RV and diastole. M-mode echoed through the RV can be compared to the ECG signal above the wall. The RV collapses after the T wave on ECG, showing classic RV diastolic collapse. These images represent findings consistent with pulmonary embolus. The top image shows a rare finding of an actual clot visible in the right ventricle, associated with a dilated right atrium, a hypercontractile right ventricle with spared apical motion, and a dynamic empty left ventricle. The bottom image shows the embolus shooting back and forth from the left ventricle to the left atrium. The image to the right of the screen shows a transgastric view showing the dilated and hypercontractile right ventricle and the clot in the center of the right ventricle. This video shows a series of images associated with progression of a PE, from initial appearance of a clot in the right atrium to dilation and failure of the RV with apical sparing of RV function, to akinesis of the RV with chest compressions. Apical sparing may be due to the apex being pulled along by the hyperdynamic right ventricle. Here we see an akinetic right ventricle and dilated right atrium. The septum bows into the left ventricle, suggesting RV pressure overload. The lateral RV wall does not move. This is consistent with ischemic RV failure. These are similar images of ischemic, severely hypokinetic right ventricles with dilated right atria, consistent with RV ischemia and failure. This set of loops serves to demonstrate a classic congenital abnormality. The tricuspid valve is extremely apically displaced, and an ASD is also present. This syndrome is known as Epstein's anomaly and may also be associated with Wolff-Parkinson-White conduction disorders and other congenital anomalies. The atrial septum can be assessed in the bicaval view at 60 to 120 degrees, focusing on the right atrium. Color flow at a low velocity, around 20 to 30 centimeters per second, can reveal flow across the septum, consistent with a PFO or ASD. While some lipomatous or fatty changes of the septum are a normal variant and produce a dumbbell-shaped septum, this large septal lipoma or adenoma is very unusual and appears to be blocking inflow from the SVC. It would likely produce an SVC syndrome and require operative removal. In conclusion, the right heart requires careful evaluation just as the left heart does. Remember that TAPSE is useful for assessing RV function. Understand which leaflets of the tricuspid valve are visible in which views. Finally, be able to identify views and signs in the diagnosis of right heart failure due to tamponade, PE, and ischemia.